Hi, everyone. Thanks so much for coming. So I'm Hayley Merkeley, and I'll tell you a little bit more about myself in my presentation and what I do. But today I'll be talking about what is a hematologist, because when I was an undergrad, I had no idea that there was even such a thing as a hematologist. So as you guys are affiliated with blood research, I thought it'd be helpful to kind of give you a clinical perspective. So I'm going to provide an overview of the field of clinical hematology, discuss the training pathways to become a clinical hematologist, highlight my own career trajectory as an example, and review some interesting cases from my practice to hopefully inspire some interest in the clinical aspects of the research that you're doing. And hopefully I can answer your questions about anyone who's interested in clinical training and wanting to pursue this pathway. So how many people are in medical school or thinking of attending medical school in the audience? Yeah. Okay, we got a few people. Excellent. How many of you are thinking about a career in hematology? Okay, great. And who knows what a hematologist actually does? Thank you, Ed, a close collaborator for many years. So if you ask the Royal College, which is the accreditation body for specialists in Canada, what a hematologist is, they will say that hematology is the branch of medicine concerned with the clinical and laboratory investigation, diagnosis, and medical management of diseases of blood-forming tissues, and lymphatic tissues. And when you look at their website a little bit further, they break down kind of key aspects of hematology practice. So classically, hematologists have focused on either benign, which has now been rebranded classical hematology, versus malignant. Historically, people did a little bit of both, but as the breadth and depth of the field is increasing, generally people will kind of divide into either classical or malignant. You can be a generalist. Most people who are generalists would be working at smaller community hospitals, or you can have a subspecialty like I do, and I'll walk you through my subspecialty training. We do both inpatient and outpatient care, and the variety of cases that you can see can range from patients with slightly abnormal lab values on their complete blood counts or some of their coagulation parameters, to life-threatening hematologic emergencies where patients are in the ICU and needing support and treatment. A really key aspect of our practice is longitudinal care. So not only are we involved in the initial assessment and diagnosis, but we follow patients throughout their treatment course. We treat exacerbations of their underlying diseases. We treat relapses of their underlying diseases. And often we're providing end-of-life care because unfortunately some of our, especially malignant conditions, can be life-limiting. We do some procedures. So people who are, like procedurally oriented professions, we're not like surgeons, they're pretty limited, but we do use our hands a little bit doing things like bone marrow biopsies, intrathecal chemotherapy, where we would do a lumbar puncture and administer chemotherapy around the spinal cord. And a lot of hematologists have lab-based professions as well. So especially out east in Ontario and Quebec, it's actually clinical hematologists who often run labs and are providing interpretation of blood cell morphology, coagulation, and transfusion medicine. Here, it tends to be more hematopathologists who do that, which is a separate training pathway that I'll mention briefly. And you can have variable practice settings. So you can work at an academic hospital where you have lots of residents and medical students working alongside with you. You can work in a community hospital where you're the sole provider. You can do more kind of outpatient clinic-based practice. And as I mentioned, you can even run a lab. One of the things I really like about hematology is we do a lot of interprofessional and interdisciplinary care. So I work quite closely with nurses and pharmacists and physiotherapists, which adds to the care that we provide to our patients. So how does one become a hematologist? So if you want to become an adult hematologist, you have to do general internal medicine first. So after medical school, you would apply to CARMS, which is the Canadian Resident Matching System. So you would apply to internal medicine programs, get accepted, complete 3 years of general internal medicine training, and then do it all over again for hematology. You have to write board exams in both internal medicine and hematology to be certified. This is in contrast to if you were training in the US, for example, they often do combined programs with hematology and oncology, where you actually do 3 years of training. And a lot of people in Quebec will do that as well. They'll do a combined hematology oncology fellowship. If you do that, you have to write a third Royal College exam, which are board exams and are kind of very stressful and lots of months of studying. So definitely was not appealing to me to want to do. You can also enter through pediatrics. So you would do your general pediatrics training. I think it's around 3 or 4 years as well. And they are actually dual trained in hematology and oncology. So you don't have that option to kind of separate out. But again, it's 2 CARMS matches and 2 Royal College exams. And then there's hematopathology, which is its own separate entry program after medical school. It's 4 years, as opposed to clinical hematology is 5 years. And you can go directly after medical school. There's no kind of interim training program that you have to do, like internal medicine or pediatrics. So when we think about the subspecialties of hematology, it's kind of divided based on how blood cells develop. So classical hematology or non-malignant hematology is things like thrombosis, which is blood clots, hemostasis, so bleeding disorders, red cell disorders, which is my area of interest, so conditions like sickle cell anemia and thalassemia, and transfusion medicine is a big component of classical hematology as well. In malignants, we break it down into myeloid or lymphoid specialties. So myeloid are things like acute myeloid leukemia, myeloproliferative neoplasms, along those lines. Lymphoid are things like lymphomas, myelomas. And then there's a kind of additional training that you can do once you kind of do your basic malignant training, which is to specialize in either stem cell transplant and or cellular therapy, which we'll talk about a little bit when I show you some cases of some of my patients. So whenever I have a question these days, who do I turn to? ChatGPT. And so I asked ChatGPT, who is suited for a career in hematology? And it gave me about 25 options. But I picked the most salient ones, I think, that really stood out to me. So ChatGPT says problem solvers, people who enjoy diagnosing and managing complex medical conditions. And this is very true because blood is literally everywhere. So some of the presentations that we see in hematology can affect multiple organ systems, very unusual presentations. Curiosity and lifelong learning. So this is a rapidly developing field. Like even from when I completed training to my career now, the advances that I've seen, which is only like 7 years, the advances that I've seen in therapeutics and options for patients is just like entirely paradigm shifting. So it's really a specialty that's kind of at the forefront of medical science. Science enthusiasts. So people who have a great understanding of the human body at a molecular level. A lot of our therapies that we use in hematology are targeted at a molecular level. So certain mutations, we have designed drugs to overcome the limitations of those mutations. Research-oriented individuals. So a lot of my colleagues are involved in clinical trials, investigator-initiated trials, looking at all with the goal of improving the care that our patients receive. and patient-centered care. So as I mentioned, a lot of our relationships with our patients are lifelong. Many of them have life-threatening conditions, which can be obviously very alarming and scary to a patient and their family. So really having an empathetic approach to provide the emotional support that these patients need is key. Embrace of technology. We'll talk about, when I present to you the cases, some of the new technological advances that we've seen. And you know, this is definitely something like I've had to go back to my cellular biology textbooks and my immunology textbooks as the field has advanced to really kind of understand how we're using this technology now to treat our patients. And probably what I love most about hematology is how visual it is. So you'll see the slide there. So this is a normal peripheral blood film. We've got mainly red blood cells that you can see there, those nice little round things. Got a few white blood cells, those kind of purpley things, those are neutrophils. And then you see a patient, you take their history, you examine them, then you look at their blood film, and you can clearly see that there is a big distinction between normal. So this is a patient with a chronic lymphoid condition called CLL, or chronic lymphocytic leukemia, where they have an excess of lymphocytes. Those are those purple cells there. You can see they're kind of smashed up and smeared all around. Those are special cells that we see called smudge cells. So seeing a patient having that visual input of knowing exactly what's wrong with them, the fact that it's objective, the fact that it's visual are things that I really enjoyed about hematology when I was thinking about careers. So my journey to becoming a hematologist, so I did my undergrad in Victoria, 4 years, and I did kind of a less typical major, so biopsychology and Spanish. Then I did my MD here, which was 4 years. And then I did internal medicine here, which was 3 years. Then hematology, which is a 2-year training program, as I mentioned. And then I actually did a fellowship in red blood cell disorders, which was another 2 years. So you can see the years kind of adding up. I was a 7th year resident at the final stages of my training. And where did that get me? What do I do now? So currently, I am the medical director of the Red Cell Disorder Program of BC, which is based at St. Paul's Hospital. So we see all the patients in the province and the Yukon with sickle cell anemia, thalassemia, and other red blood cell disorders. So I do that 2 half-day clinics a week, often involved in clinical trials for these patients, allowing them to access new kind of therapies. Do some collaboration with CBR researchers. So Dr. Ma and I have a collaboration going on right now to really inform the care for our patients in future. I also do more kind of general classical hematology at my private office, which is just outside of St. Paul's. Again, that's about 2 half-day clinics a week. And as part of that, I have to do inpatient call at St. Paul's, where we're seeing very sick patients in the hospital who are needing chemotherapy and consultations on blood issues. I also do apheresis medicine. Anyone know what apheresis is? So this is a special therapeutics. You can kind of think of it similar to hemodialysis, which I'm sure most of you have heard about, where we take patients' whole blood, we remove it, we spin it, different cells will separate out by density, and we can throw out what we don't want. So if patients, for example, have problems with their red cells, so if they're having complications of their sickle cell disease and we want to get rid of their red cells, we can spin them out, throw them away, give them new red blood cells. Similarly, if patients have antibodies in their plasma that's causing problems, we can discard the plasma, give them new plasma or liquid components of their blood. So that's a specialized service that in BC is only offered at VGH. And so I do that for 9 weeks per year. And I'm also the co-director of the training program for hematology. So this is why I'm here. I'm planting the seed early. We have a need for hematologists in the province. And, it's a really, as I hope I will impart to you, it's a wonderful career. We also have once you've completed your core hematology training, my colleague Shannon Jackson and I have started a fellowship program for people who want to specialize in bleeding disorders and red cell disorders. So I wanted to just talk about some of the patients that I've seen in my practice recently to give you a bit more of a tangible flavor of what we actually do day to day. So this is one of my patients. She was 45 when she presented to hospital with a 2-week history of a neck lump and some abdominal pain. She had a lymph node biopsy that showed aggressive lymphoma. So when we're thinking about lymphomas, we break them down into indolent, which often grow over many years, and aggressive, where patients can become very symptomatic within a few short weeks. We worked her up in the hospital, did some staging investigations, including CT scans. We performed a bone marrow biopsy and started her on chemotherapy. So she completed 6 cycles of our standard chemotherapy, but unfortunately at the end of that still had active lymphoma. So the plan was to start her on a new chemotherapy and refer her for an autologous stem cell transplant, where using the apheresis technique that I described to you, we are able to collect her stem cells, give her high doses of chemotherapy that would otherwise kill her, but then reinfuse her own stem cells so that she can hopefully get rid of her lymphoma. Unfortunately, though, that plan did not fully work out. So she had progressive disease on her chemotherapy. So we decided to treat her with CAR T therapy, which eventually gave her stable disease. So what is CAR T? So this is one of the most exciting developments in hematology in recent years. So basically, we are targeting patients' immune systems to treat their hematologic cancers. So using the apheresis technique that I described, we're able to selectively isolate the T cells. They are then taken to a lab. They are engineered to target whatever antigen you're looking for. So in the case of lymphoma, it's usually CD19. Those are reinfused in the patient following conditioning chemotherapy. And then the idea is that they're going to target the lymphoma cells and kill them. And so my patient had this procedure and now 14 months out has stable disease. So it's really been a game changer for the care of patients with relapsed and refractory B-cell malignancies. Here's a second patient that I saw recently. So she's 18 years old. She has transfusion-dependent beta thalassemia. So beta thalassemia is when you are missing genes that help, that encode beta globin, which is a key component of hemoglobin. So without those genes, you are unable to create functional hemoglobin. So as a result, usually starting on in very early childhood, patients need red blood cells every month. Otherwise, they wouldn't grow, they wouldn't develop, they would die in early childhood. Now, the problem with giving people red cells on such a regular basis is, as you probably know, we don't have any great mechanisms for excreting the iron that comes with those red blood cells. So patients can develop iron overload. That can lead to heart failure, can lead to liver failure, it can lead to dysfunction of the pituitary gland and all sorts of hormonal problems. And so, up until we had effective iron chelation agents, patients were dying of iron overload very early in adult life. So as a result, patients need to take iron chelation medications regularly. They often have a lot of side effects. There's issues with adherence. And so there's a lot of kind of support that we have to do for these patients to ensure that they're taking their chelation properly. But this is again a new therapy that's come out. She undergoes gene therapy as part of a clinical trial. So this is the first commercially approved CRISPR-based therapy. So using a CRISPR platform, we are knocking out a gene called BCL11A. BCL11A is the suppressor of fetal hemoglobin, which is a hemoglobin that we have in small amounts in adults, but is our main hemoglobin in fetal and early life. If we knock that gene out, we are allowing increased levels of fetal hemoglobin, which will thereby increase the total hemoglobin. And patients become transfusion independent. They can come off of their iron chelation. And so I have been following her for 3 years now, and she's still completely off of transfusions, still completely off of iron chelation. I still have to follow her because this is a brand new therapy. We don't really know what the late toxicities will be, but the FDA has mandated that all these patients are followed for 15 years because there's some concern that the gene therapy could go off target. Patients could develop malignancies if it inserts into an oncogene. So the way this works is, again, we're using apheresis. So we are selectively collecting the stem cells. Those are taken to a manufacturing facility using electroporation. The stem cells, we make little holes in them, and the CRISPR-Cas9 system is delivered, and it will target that BCL11A gene. These are then reinfused to the patient after quality control, and the patient receives conditioning chemotherapy. And then we wait for them to engraft. And so this usually requires a month in hospital, recovering from the effects of the chemotherapy, waiting for the new stem cells to set up in the bone marrow and start producing normal blood cells. But absolutely life-changing for patients. This therapy has also been approved for sickle cell disease. So it's under review by Health Canada right now, and hopefully something that we can start to use more widely outside of clinical trials. Okay, third patient I want to tell you about. So this is an 80-year-old man who presents to hospital with extensive bruising. His factor VIII, which is a key component of our coagulation system, is undetectable, and he's found to have a high titer antibody to factor VIII. So he doesn't have any factor VIII available, so we have to circumvent that. So we provide him a factor VIIa, which I'll show you. And we need to get rid of his antibodies. So he needs to be immunosuppressed to allow the production of his own factor VIII again. So this is something called acquired hemophilia A. So of course we have congenital hemophilia where people have mutations in their factor VIII genes and are born without the ability to synthesize factor VIII. But in older people with underlying cancers, pregnant patients, sometimes you can get antibodies that will attack factor VIII. So patients will very commonly, with no kind of previous history of bleeding, present with extensive bruising, extensive muscle bleeds. Bleeds can be life-threatening in these patients. And this is not, of all the acquired hemophilia patients I'd see, these pictures are very typical of what we often see when these patients come to hospital. So very dramatic. We talked a little bit about, you probably have a little bit of familiarity with the coagulation cascade. This is not this is a simplified version of it. Factor VIII, as you can, I don't know if I have a pointer. I do, this is my pointer. Yes, okay, so factor VIII is up here. So because we're missing that, we end up bypassing it entirely by using factor VII so that we can then form our stable fibrin clot. So we have actually this product that we can infuse to patients and help stabilize their bleeding. Okay, patient journey number 4. So this is a 20-year-old woman with sickle cell anemia. So sickle cell anemia, as I've mentioned, is a red blood cell disorder. So again, it is a mutation in beta globin, but rather than having decreased beta globin production, you are producing a functionally abnormal beta globin or hemoglobin S. And what that does, it leads to, rather than having those nice round red blood cells that I showed you earlier, it distorts the hemoglobin within the red blood cell, and so they become sickle shaped. And that can lead to problems called vasoocclusion, where the blood doesn't flow well through the vessels. And these cells also prematurely break down or hemolyze. So she's 18 weeks pregnant, and she developed something called acute chest syndrome. So that's a condition where you get sickling phenomenon in the lungs. And so patients can actually go into full-on respiratory failure where they would need to be on a ventilator and supported. So she's on high flow oxygen. The way we treat this is we have to remove that sickle hemoglobin. So again, we can do an apheresis procedure called red blood cell exchange, whereby we're discarding those sickle red blood cells, giving patients new blood cells, or sometimes we can just give them simple transfusions to overcome it and dilute out that abnormal sickle hemoglobin. She's given antibiotics. Her pregnancy is closely monitored, and she ends up delivering a healthy baby boy, which is probably the most satisfying part of my career. The nice thing about working with patients with congenital disorders is you're often working with really young patients, and you get to help them through kind of their seminal life moments, like graduating from college and getting married and having children. And for many of these patients, so they were told as children, that they probably wouldn't live beyond early adulthood. And the fact that we're able to improve medical science, help these patients achieve the things they want to do in life, and expand their lifespan is just really a special thing to be a part of. So what we do in our clinic is we have to check for all the organ systems for damage related to the disease. So she has lots of screening investigations that she ends up doing. And we start her on a medication called hydroxyurea, which is standard of care for patients with sickle cell disease. It increases fetal hemoglobin, which, as I mentioned, will increase total hemoglobin. That also has the added benefit of diluting out the sickle hemoglobin. So patients have fewer ping crises and problems related to their sickle. So this is just an example of acute chest syndrome and what's actually happening. So as you can see, rather than having those nice round red blood cells, here we get the sickle deformity. Those will cause decreased blood flow in the lungs and decreased oxygen delivery, and patients can actually have significant respiratory failure. Okay, last patient journey before we take some questions. So this is the 35-year-old woman that I just saw like a month ago. She presents to a community hospital with complaints of fatigue, dark urine, and bruising. Her platelets are 4. Normally they would be much higher than that, so about 150 to 450. And her hemoglobin is low, it's 65. Normally, again, much higher. And she has evidence of her red blood cells breaking down or hemolysis. So there's additional kind of chemistry tests that we look at that support that. We look at her blood film, and she has extensive cells called schistocytes, which I'll show you a picture of, and severe thrombocytopenia or low platelet count. So she was from a rural community in BC. So this is one of our life-threatening hematologic malignancies called TTP, or thrombotic thrombocytopenia purpura. So we had to transfer her air ambulance, life or limb, to Vancouver General Hospital to start treatment with plasma exchange and immunosuppression. So what TTP is again, it's an antibody-mediated disease. So you have an antibody against a metalloproteinase called ADAMTS13. So its normal physiologic role is to cleave von Willebrand factor multimers. If you don't have that ability, these multimers distribute all over the vasculature, and it leads to cells being consumed and sheared. That's why you get the low platelets. That's why you get the red blood cell breakdown. So untreated, the fatality rate of this is like 95%. And so plasma exchange, removing that antibody, and providing new ADAMTS13 through donor plasma is how we treat this disease. So with this therapy and with immunosuppression, she's stabilized and is able to be discharged from hospital 2 weeks later. So these are the schistocytes that we see, these little kind of abnormal cells that have literally been sheared by those von Willebrand multimers. And so with the use of plasma exchange, we are able to restore her blood to normal, which is pretty cool. And again, I love that visual of seeing something very abnormal, being able to fix it and look at it under the microscope with your own eyes. So I am happy to take any questions that you may have about careers in hematology. And yeah, hopefully being part of the CBR and doing some projects has inspired some interest in hematology, or at least collaborating with hematologists in future. And yeah, I open it up to you guys.
Well, I don't have a question about a career in hematology, but I do have a question about lymphatics versus blood vasculature. And I'm wondering if there might be differences between lymphatic repair and blood vasculature repair. Are there known differences about how lymphatic repair may occur? Do you know of any disease states that might occur?
Great question, Ed. Yeah, no, off the top of my head, no. Again, I'm a subspecialist with a very narrow focus. So yeah, I'm not within my realm of red cell diseases.
I'm thinking there should be.
No.
Yeah, so your thalassemics and your sickle cells, you actually get involved in genetic counselling and looking at the spouse, because then the last thing that lady should have done is marry someone with sickle cell trait for starters.
Yes, yeah. No, it's a key component of what we do is the genetic counseling, yeah. And we're actually seeing rates of thalassemia decline in the developed world because we have effective screening and counseling programs. Very different in the developing world where they don't have access to screening or counseling resources. It's happening. So the therapy that I just showed you, so it's called XSL. And it is approved by the FDA, it's approved by the EMA, it's approved in the UK, Saudi Arabia, Bahrain, and it is undergoing Health Canada review. Where everybody is kind of at a standstill right now is the economic analyses. So this is not an inexpensive therapy. So market value is probably going to be around $2 million per patient. And that does not include the cost of the patient needing to be hospitalized for a month, undergoing the chemotherapy, the stem cell collection that you need to, which of course has significant costs. That being said, often, the morbidity of these diseases, the lifetime cost of a patient going through medical system often approaches that same amount, like millions of dollars. So, in Canada, we have the Canadian Drug Agency, which does economic analyses for new therapies. So we are also undergoing a simultaneous review by the CDA. Hopefully get the Health Canada and CDA results in the fall, which is now. So maybe a month or so.
Looks like our beloved director has a question for you from Toronto.
Hi, Ed.
Hi, Hayley. That was fantastic. First, Ed, to Ed's question about lymphatics, there's certainly infectious diseases, tropical diseases that affect lymphatics that grow and shrink and heal. But that's really not why I jumped in. That was fantastic presentation, and there are hematologists out there I can see, and there are others who are at various stages in their career. Early and slightly later. From one myself, I took even a longer circuitous route than you did, Hayley, to get to the hematology world. The path, I'd encourage you all out there, and no matter what age, almost no matter what age, to really think about this. Medicine itself is a great the path itself is fantastic, even if you don't end up in hematology, God forbid. And it's a fantastically exciting field, much more so than it probably was 20 plus years ago, where it was there was less that we could do, and there was less known, certainly from a molecular point of view and from a technological point of view. So it's really an exciting discipline, and even more exciting now, and particularly now that we have fantastic teachers and mentors to lead us forward. So don't just because you have a PhD think you can't, oh God, I've already put in so many years. That's not the end of your life, to be sure. So that's my little pitch.
Thank you, Ed.
So I was wondering if you could follow up a little bit more about the about paying for like expensive therapies, like particularly things like CAR T. Like, I know there was a whole saga about that. Like, how is it decided what therapies get paid for, and how do you get access to your patients?
Yeah, so we have a not so great system in Canada. Unfortunately, it tends to be a lot more bureaucratic than a lot of places. So that's for like the health and safety approval. So Health Canada has to do that first. Their process is slower. Often a challenge as well is, especially for rare diseases, which I focus in, the drug companies are not necessarily interested in entering our market because of the lengthy bureaucratic processes and the money that they have to pay when they're going to have a relatively, small amount of patients versus bigger markets like Europe and the US. So that's the approval aspect. In terms of the economic analyses and how drugs are paid for. So the CDA, the Canadian Drug Agency, is the first step. So they have health economists who they talk to, the company submits information about it. They speak to experts in the disease field. They speak to patient groups to inform their analysis, and then they do their analyses and make a decision whether it makes sense to fund or not fund. That's level one. Then there's an endorsement level from the Pan-Canadian Pharmaceutical Alliance, which will say, yes, we endorse this or not. And then it goes down to each individual province. And so there can be a lot of inequity province to province. So a classic example, and Vivian, my summer research project student, is working on this, is ITP, or immune thrombocytopenia purpura, where certain classes of drugs are funded in some provinces, not funded in others. And so the care that patients get province to province can be very inequitable. So yeah, it's not an amazing system. And sometimes patients will move to a particular province because if they have a particular condition, they know that they can get their medications covered. A lot of patients with rare diseases that need expensive medications, we tell them, like, try and work for the federal government. They have the best benefits plan that can help support payment for these medications, because otherwise they might not be able to receive them.
With the CAR T, originally, I think the stuff went to Seattle. Are we doing it locally now, the processing?
Yeah, so we have been doing it as part of clinical trials for a few years now, but we just got standard of care CAR T therapy years behind other provinces, again, because of this inequitable decision-making province to province. So March was when we got standard of care CAR T. So previously we were having to, so my patient that received CAR T that I showed you, I had to send her to Toronto to Princess Margaret Hospital to receive that. So she literally had to pick up her life and move to Toronto for a month. The Ministry of Health at BC did pay for that, but it's a pretty big ask for a patient with a life-threatening condition to, move to another province for a month. Hey, Eric.
Yeah, thanks for that presentation. I had a question. You mentioned earlier that BC needs more hematologists, and I'm wondering if you see barriers in recruitment of hematologists into the residency program, since they have to go through internal medicine, or is kind of the limiting factor just the number of residency spots and government funding for those positions, which I've heard has kind of limited the number of medical spots for medical students in general?
Yeah, so I mean, historically, we were training fewer hematologists per year. Now, so each year we have to kind of submit to the Ministry of Health how many positions we'd like. The different internal medicine subspecialties agree upon, who's getting what and how are we dividing up this pie. And then the Ministry of Health will fund positions based on our kind of submission and what they think we should be doing. So we have increased our training spots. I think part of the challenge with hiring hematologists in the province has been you need a lot of kind of ancillary services. So you need a good lab. You need a critical mass of a call group to help support. So our regulatory agency, the College of Physicians and Surgeons, we have to provide 24-hour support to our patients. And so obviously one person can't do that. So you usually need a call group to help support your patient. So when I'm on call, for example, I'm taking calls from all my colleagues' patients within my call group 24/7. And so I think, the other thing is it's not a particularly well-paid subspecialty compared to other subspecialties. So, a lot of hematologists have worked out having their overhead paid for by a health authority and things like that. So though I think the barriers are often more kind of health authority level. And once we are able to iron those out and have, supports for hematologists in practice, it'll be easier to funnel trainees into the program.
Thanks for the talk. That was amazing. It's cool to see like all the different things that you do. Like you wear so many different hats in your job. I wanted to ask kind of, I guess, a more personal question about work-life balance. Like, how do you find it is wearing all those hats, and like how many hours are you working per week? I'm sure it varies a lot.
So I've accepted that work-life balance is, it's not balanced. There's some times that my life, so I have two little kids. I have a 6-year-old, I have a 3-year-old. So I'm a mom too. That's my other most important job. There are times where my work life is way busier and I can't spend as much time with my kids. And then there are other times when, I can make my family life a bit more of a priority. So I think it's a lot of push and pull, and like at no point in my life do I feel like, oh, I'm perfectly balanced and doing everything well in each aspect of my life. And I've, I always say like, so the kind of 3 main things that I have to do as part of my job are my emails, checking my electronic medical record at the hospital, and then my one in my private office. And I've decided that I can only do 2 well at once. So some days it's the third one is, and it alternates which one it is. But that, yeah. So how much do I work in a week? Again, it depends on the week. It's more than a 40-hour work week. But a lot of, you can kind of tailor how much you want to work as well, right? Especially if you're working in a city that's not Vancouver, where you don't have to pay for a mortgage. Some people will choose to work less and can have a little bit more time. So.
Getting back to recruitment, in some ways you're the victims of your own success. The prognosis of so many things has improved with longitudinal care. So you're really in a growth industry.
Yes, absolutely. Yes. So we do have patients who are living longer. So even though the incidence of many of our diseases is not increasing, the prevalence is, because these patients are doing well on the therapies that we have now.
Hi, I was wondering if you could describe a little bit more about some of the differences in a career or between a career in hematology versus hematopathology in terms of like scope of practice and like a general day in the life.
Yeah. So hematopathologists are lab-based. So they are usually, always working in a hospital. They won't have a private office outside of the hospital. So they're usually hired by the health authority. They do have some interaction with patients in contrast to a lot of other pathology careers. So For example, at my hospital that I mainly work at St. Paul's, it's the hematopathologists who do the outpatient bone marrow biopsies. So they're going up and meeting the patients and doing the procedures and interacting with them. And again, it kind of depends on what center you work at. So the pathologist at St. Paul's, for example, Cedric used to be one of them. So he might have more informed comments, but we are a coagulation lab for the province. So they oversee a lot of the specialized coagulation tests. We have a transfusion medicine component, so they oversee the transfusion medicine lab. So there is quality assurance and things that have to go into running a lab that they're responsible for. We, as clinical hematologists, don't sign out our own blood films. In some parts of Canada, they do. So it'll be clinical hematologists who are reviewing blood films and signing them out. But here it's the hematopathologists that do that. They do most of our lymph nodes all of our lymph nodes go to anatomic pathology. So hematopathologists don't do that. But they do the bone marrow biopsies as well. So interpreting and signing those up.
Just to sort of beat the hematopathology drum, I was actually originally trained in clinical hematology. Came here and got a position in the pathology department. The nice thing was that one was salaried, didn't have all the kind of business of running an office and fighting overhead. So hematopathology is an attractive specialty. Also, it is to a certain extent time limited, and so particularly for women with families, I think it's a finite commitment, whereas you're in straight clinical practice, it gets a lot more complicated.
Yeah. Yeah. I mean, I wish I had known that it was a career option earlier on. But yeah, I came to medical school. I didn't know what a hematologist was. And then we did our blood block and I was like, oh, this is kind of cool. And so, yeah, which is in part why I wanted to give this talk, because I think a lot of people are in a similar position.
Any final questions for Dr. Merkeley? Thank you so much for coming to speak with us today.
Yeah.